I keep jumping the gun on that, and then I have to just repeat my intro. Well, thank you so much all for coming to the 9th International Symposium on Alagille syndrome. We're here with the My City Med platform with both Jeff and Eden Lord, who are hosting this in the background. So thank you guys for doing that. And so far, so good. Hopefully everybody got a little lunch. I'd like to introduce Dr. Jeff Feinstein with Stanford Medicine, Lucille Packard Children's Hospital, as well as Dr. Noel Ebel. Both of them have been unbelievable supports for Alagille Syndrome Alliance. They have recently opened up the Alagille Care Clinic there at Lucille Packard Children's Hospital, and we rely on them for many, many things. We just are so grateful that they're here. Thank you both for coming. And I'll let you guys kind of introduce yourselves a little bit. Take it away.
Perfect. Thanks, Roberta. Thanks, Shara. Thanks to obviously the Alliance for everything that they do for the families, for the kids, quite frankly, for Noel and I. Thank you to CityMed for doing this. I went wandering aimlessly through the website before to see what was what and what is there, and it's amazing. It's really easy to use, and the information that it's going to contain is going to be spectacular. So a big thank you to everybody who makes all of this possible. And I'll start by thanking Noel as well for being a good partner in what we do. We're going to partner in this presentation. I'm going to start, she's going to jump in, and then we're going to go back and forth just a little bit. So to start with, the topic that we were given were cardiac concerns in Alagille syndrome. And to be honest with you, I wasn't completely sure whether this was the parents' concerns or my concerns as it relates to cardiac concerns. So I decided to touch on both. So we'll go through some of the issues I think that maybe are going through your heads, and certainly issues that I think about each day when I have the privilege of caring for these kids. All right. So the first concern, I suspect, if people have been looking around on the internet, is that they have concerns that their child may have congenital heart disease. And it turns out that's a very well-founded concern. So at least 75% of patients with Alagille syndrome have congenital heart disease. And some of the more recent studies, one of which that's going to be coming out hopefully shortly from Gala, suggests that that number may be as high as 90%. And I would simply say that obviously I live in a very specific and specialized world, but we get referred Alagille kids all the time, and certainly they, quote unquote, all have some form of congenital heart disease. So the 90% number is likely going to be accurate. So the take-home message from this very simple slide is that if you or your child have not been evaluated for congenital heart disease, please ask. Doesn't mean that it's necessarily congenital heart disease that is going to need treatment, but it could. And there certainly are forms of congenital heart disease where you may be completely asymptomatic and still benefit both short and long term from some form of treatment. Okay, so now that I've told you that 90% of patients with Alagille syndrome have congenital heart disease, now I've of course made you much more concerned. So is there a cause for this concern? And what I would simply say is that on the positive side, treatment for congenital heart disease in and of itself leads to improved quality of life and life expectancy, whether you have Alagille syndrome or not, quite frankly. That being said, there are certainly causes for concern in this special population. The liver disease can complicate the surgical approach for congenital heart disease. If the treatment for some forms of congenital heart disease is not undertaken, and I'm going to say in time, and that's a very nebulous term, liver transplant may not be an option. And in fact, we will routinely see patients or be referred patients where the families are told that the liver is too sick to have heart surgery, but the heart surgery is too complicated in the setting of a sick liver to be able to enable them to get liver transplant. So it's a bit of a catch-22. So we try to be quite proactive in taking care of the forms of congenital heart disease to make sure that if and or when a liver transplant is needed, that the congenital heart disease will not prevent that from happening. That being said, that in some forms of congenital heart disease, and I'll talk about this a little bit later on, even when repaired, they can complicate liver transplant. And we here are very fortunate to have an experienced transplant team who is used to working with these patients. But I can assure you that some of the patients that we send them for transplant, it makes them a bit nervous and gives them quite a bit of pause. So I'm going to go through the basics of congenital heart disease to hopefully ease at least some of the concerns, but please, if there are questions, please just drop them into the chat box or raise your hand. Let me go from here. So here's the normal heart. And for orientation, all of the drawings, all of the imaging studies are as if you are looking at the other individual, at the patient. So if you see on screen left, there are the two kids. So the left of the heart and the left of the body is actually relatively screen right. And the right side of the patient is actually on screen left. So in this normal diagram, the blue blood, illustrated by the blue arrows, comes in through the right atrium, into the right ventricle, and out through the pulmonary valve to the pulmonary arteries and into the lungs. It picks up oxygen and then comes back through the left atrium. The oxygenated blood now shown in red, left atrium, into the left ventricle, and then out to the body. So the two systems work in parallel with the blood never mixing. I've added the pulmonary arteries to this simplistic drawing to show you, in fact, that the pulmonary arteries themselves are not at all simplistic. They are highly branched with hundreds and hundreds and hundreds and hundreds of branches of varying size within the lungs. And we often refer to this as the pulmonary vascular tree, right? So if you think about it, it has a main trunk and then lots of branches that continue to get smaller and smaller until they get to the smallest leaves, which we would consider the breathing system or the alveoli. In Alagille syndrome, the vast majority, well over 2/3 of the congenital heart disease that we deal with is on this right side of the heart, meaning something along the lines of the pulmonary valve, the pulmonary arteries, with or without other forms of heart disease. And I'm going to go through a couple of examples. So here's one specific example of a form of congenital heart disease called a septal defect. So the wall between the two chambers of the heart, whether the top two chambers or the bottom two chambers, are called septa or septum. Since the top two chambers are called atria, a hole in the wall between the top two chambers is simply called an atrial, top two chambers, septal, wall, defect, hole. So there's a hole in the wall between the top two chambers. That's an atrial septal defect or ASD. Similarly, if the hole happens to be between the bottom two chambers in the ventricles, then it's a ventricular septal defect, a hole in the wall between the bottom two chambers. Well, these lesions are actually incredibly common in children in general. In and of themselves, in isolation, for example, they are not at all common in kids with Alagille syndrome. What is really common in these kids is something called pulmonary artery stenosis. Now, this picture, I will say, is an oversimplification. This just shows a narrowing in the sort of the main or central piece of the pulmonary arteries, and it shows one narrowing. In kids with Alagille syndrome, most of the time, there are multiple narrowings in many different pieces of the lung and in both sides. So it's not just one narrowing close to the heart. There are many, many narrowings, both close and far away from the heart. And I'll show you a few pictures of these in a moment. Tetralogy of Fallot actually combines, if you will, 2 or 3 different forms of congenital heart disease into one. The first piece is the ventricular septal defect, right, between the bottom two chambers, this hole here. And then the second piece is this narrowing or complete closure of the pulmonary valve. So either pulmonary valve stenosis, narrowing, or pulmonary valve atresia. Atresia simply means that it is completely closed. There is no opening. One very special form of this, tetralogy of Fallot with pulmonary atresia and MAPGAs, is probably the most complicated form of congenital heart disease involving the pulmonary arteries that we deal with. And so you can see in this bottom left picture, by comparison with the top picture of the normal heart, there's a hole between the two chambers, but there is actually no pulmonary artery shown, meaning that there is no connection between the right ventricle and any form of the pulmonary vascular tree. The pulmonary arteries, they form separately and in multiple different pieces. So you can see one piece going off to screen right and one piece going off to screen left. Now, in some of these patients, there may be 1 or 2 MAPGAs, or there could be 6 or 7 or 8 MAPGAs. These are a couple of pictures of what these MAPGAs can look like. And we did a study not that long ago of well over 200 patients. And the really interesting finding was that almost no two were exactly the same. So every individual with MAPGAs, and this is with or without Alagille syndrome, has their own map. They're all different. They all combine or separate differently, and they all need a very individualized approach to getting them cared for. So if you look at the picture in the top left corner, the large structure running vertically, top to bottom. Actually, I should ask a question. Can you guys see my mouse?
Yes.
Perfect. So the structure running vertically, this is the aorta, okay? And you can see multiple vessels coming off the aorta. 1, 2, 3, 4. Each of these vessels goes to a different piece of the lung. You can see that this goes, again, remember, this is the left side. This is the lower portion. This is sort of the middle portion. And over here, this is the right side. So this will go to the lower portion of the right, and this will go to the upper portion of the right, okay? Here's one MAPGA that supplies most of the right lung, right? And here's a MAPGA that supplies the right lung, and then actually has a connection that comes across the center to feed a piece of the left lung as well. So in order to better understand the details of the forms of congenital heart disease, we do various forms of testing. The most simplistic form of testing that we do, that I suspect everybody is very familiar with, is an echocardiogram. This is simply a diagnostic test. It's ultrasound. It can be done quickly and easily as an outpatient on kids and adults of all ages and all sizes. It does not hurt, though the kids are often not particularly excited to get it done. And we can get the overwhelming majority of information from this quite simple test. During an echo, we'll take pictures, and there's three shown at the bottom. We can look at blood flow, so we can tell which way the blood is flowing and if there's any blockages. And then we can make some measurements, the size of the pulmonary arteries, for example, or we can calculate how bad the blockages are. So you can see in the pictures below that we actually get a very nice view of all of the different parts of the heart. So here's the left atrium, here's one of the valves, the left ventricle, which then pumps the blood out through the aortic valve and into the aorta. Here's a look at a piece of some of the right side of the heart. So here's the right ventricle, and it'll pump the blood out through the pulmonary artery. And here are the branches, right? You can see this black area, that's the right pulmonary artery. Whoops, sorry about that. And here's the left pulmonary artery over here. And then in this view, which is called a 4-chamber view, you can see each of the 4 chambers: left atrium, left ventricle, right atrium, and right ventricle. Now, while echo is incredibly helpful for us in making diagnoses, and as I'll explain later, following these patients, it does not, in fact, provide all of the information we often need in kids with Alagille syndrome. And so the take-home message for echo is that echo is often not enough, as it may not tell you everything that is going on. The reason for that is because echo can only see relatively close to the heart. So for example, here we are seeing the first branches of the pulmonary artery. And if I just go back a few pictures, what you're seeing by echo is actually here. You would see this piece and this piece, but you would not be able to see anything out here. And this is the area where many of the stenoses are found in the kids with Alagille syndrome. So echo can see here, but it can't see here. And sometimes what you'll see is only very mild narrowing, especially of the left-sided pulmonary artery. And the cardiologist will say, it's very mild, I don't see any issues, and they'll stop the workup there. I can tell you that people have been burned, and we've seen second opinions where there's much more significant disease than just a mild narrowing in the left pulmonary artery, which is why I go back to the statement that simply says, please, if all that your child has had is an echo and it's not completely normal and their physical exam is not completely normal, it may be worthwhile to do some additional testing. Those additional tests may include a CAT scan or an MRI. You can see some pictures, not only of the original images that were taken with the scanner, but we have the amazing ability now to create three-dimensional pictures of these images to allow us to look at all of the different branches much more clearly. So here is a beautiful example of a lovely, this is going to be actually a right pulmonary artery running this way. And if you remember, the echo can see this very, very well. But what the echo can't see is this. And if we had stopped with just an echo, we would not have seen this, we would not have seen this, we would not have seen this. On the left side, there's some very mild narrowing, and that would likely get picked up by the echocardiogram. But it would not have picked up this, and it would not have picked up this. So if you imagine looking at an ultrasound or an echo and seeing that the right pulmonary artery is quite large, and the left pulmonary artery seems pretty reasonable, it is a little bit small, but the patient is likely completely asymptomatic and everything else probably looks quite fine, many times the cardiologist will just stop and the rest of the disease will be missed. This actually happens to be one patient that we were referred where the cardiologist noticed that there was some mild narrowing, but didn't go any further. And you can see how very, very small this entire left pulmonary artery is compared to the right. The downside to CAT scans is that it involves radiation. The good news is the scans are incredibly fast, but they do require radiation. Whereas MRIs take a little bit longer, do not have radiation, but do often require anesthesia, especially in the small kids. The other test that we find incredibly important to understand the full spectrum of the disease is something called a lung perfusion scan. This is probably not as common to many of you as perhaps an echo or a CT scan, but this helps us to make decisions as to when and or whether we actually want to intervene. So this particular test, an IV is placed and a small amount of dye or contrast or tracer, as it's called, is pushed in through the IV. They then get a picture taken, which is kind of like a glorified chest X-ray, and then the machine counts how bright the contrast is on both sides. So the picture in the middle, this is basically normal. You see a fair bit of contrast here, you see a fair bit of contrast here. The reason this side looks different than this is because the heart sits in front of the left lung. And so you get a much better picture of the part of the lung that does not have the heart in front of it. So again, this is a reasonably normal lung scan sitting here on the right. Compare that to this lung scan down below, where there's clearly significantly more contrast in the right lung than here in the left lung. And this may indicate that there are stenoses or narrowings in the left that are encouraging the blood to go to the right. If this was a first lung scan, it could also suggest to us that the left side may have a lot of stenoses and be underdeveloped as well. The other test that many of you are probably familiar with is cardiac catheterization. This is done, as the name suggests, in the catheterization lab. This is an invasive procedure, unlike CT and lung scan and echo. This requires anesthesia. The children will be put to sleep, and very small tubes are placed in the large blood vessels, and then advanced into the heart and out into the lungs. You can take pressure measurements to give us a better understanding of how much extra work the heart is doing, and you can take some pictures. This is a beautiful example and looks very similar to the CT scan, where you'll notice, maybe, oh, everything's locked.
Ooh, Jeff, we had one great question also. They had a question from the audience. So they asked, if your child had a cardiac catheterization, do you still need to ask for a lung perfusion scan?
Yeah, that is a great question. And I'm actually going to get to the answer to that question when I get to the part of how do we decide what we're going to do.
Great.
So you can see in the catheterization that there are narrowings here. And the easiest way to tell that is that this vessel's fat and this piece of the vessel's not. That's how we read angiograms. Big, big, small. So that's the technical term. That's how we do it. Big, big, small. So anytime you see these areas of narrowing, those are stenoses. Over here, you can see that this area is fairly large, but this area is quite small by comparison. You may be able to notice, depending on the size of your screen, that there's something in here that looks a little bit like a scaffolding. That is a stent that's been placed, and I'll talk a little bit more about that later on. So here's the answer to that question. When do we consider treating these patients, and when do we consider surgery? For very simple lesions, like an atrial septal defect or a ventricular septal defect or something called coarctation of the aorta, the answer is simply always, if it is needed. So if the atrial septal defect, for example, is tiny, it may be there, but it's not going to cause any issues, we wouldn't do it. If the VSD, for example, is large, we would repair that whether the child has Alagille syndrome or not. So for the very simple lesions, we always repair them if in fact it is needed. For tetralogy of Fallot, the answer there as well is simple. We always repair tetralogy of Fallot. Now, for tetralogy of Fallot with MAPKAs, the answer is always, as long as there is enough pulmonary artery with which to work. So some of the kids that we see, unfortunately, their vessels are just too small to allow us to be able to do anything definitive. Other patients that have had procedures done before, some of the pieces, quite honestly, have been coiled off, meaning that in the cath lab, they take small springs and they plug up the vessels. Those can't be used once they're plugged oftentimes. So as long as there is enough vessel to reconstruct the tree, we would generally recommend that those patients get repaired. Now, for isolated pulmonary artery stenosis, it depends. And here's the answer to the question about the lung scan. So the way that we go about determining whether these patients need surgery is based on whether they have high blood pressure in the right ventricle, and or if the blood flow to the two lungs is very far from even. So normally the blood goes about 50-50 to the two lungs. If the blood is 60% to the right and 40% to the left, we don't care very much. If the blood is 90% to the right and 10% to the left, that we would care about. And the reason we would care about that is simply because if the blood is not able to get to the left lung, the blood vessels in the left lung will not grow, and the left lung won't grow either. So if the flow is very discrepant, we would intervene for that reason alone, even if the pressures are low. If the pressures are high, regardless of how the flow is distributed, we would generally intervene on those as well. And the reason to intervene for the high blood pressure is both to preserve the heart long-term, and we're talking decades, in addition to reducing the risk of liver transplant later on. Liver transplant carries a much higher risk in kids who have high blood pressure in their right ventricle than kids who have essentially normal blood pressure in the right ventricle. So the answer to the question about the lung scan is it depends on what was found on the cath. If, for example, the catheterization found fairly low pressures, I would still get a lung scan, because if the flow is very discrepant, we would still recommend doing something to fix the pulmonary artery that's narrowed. And as I mentioned, generally that's the left pulmonary artery, but not always. If the pressure in the right ventricle is high, You don't have to get a lung scan because at that point, we would recommend surgery anyway. We will often get it to see where things stand before the surgery, so we have something to compare to afterward, but it's not nearly as imperative if the pressure is low and you're trying to decide whether to do surgery or not. Hopefully that answered your question. If it didn't, feel free to ask it again.
There was one other question that, about what size does the ASD need to be, or how do you determine if it needs to be closed?
So in general, for ASDs in kids with Alagille syndrome, we would treat them exactly the same way as kids without Alagille syndrome. So the few things that we tend to look at, we look at the size of the hole. So generally something that's quote unquote large, which we would say would be anything bigger than 8 millimeters, which quite honestly, by comparison, is not that large. It's about 1/4 of an inch. But we know that kids with ASDs of 8 millimeters or more are more likely to have issues long-term. So we would tend to repair those. Oftentimes, those can be repaired in the cath lab. They don't need open heart surgery to do that. If the ASDs are significant enough that the right side of the heart, the right atrium and the right ventricle, become enlarged, we would recommend that those get closed as well. So either the size of the ASD or evidence that the right side of the heart is getting enlarged, or if there's a catheterization done, if there's enough blood flow through that hole to be important, those are the 3 reasons that we generally close ASDs. Now, if they have other things besides the ASD will often be closed at the same time as some of the other surgery, for example, for tetralogy of Fallot or for pulmonary artery stenosis.
As a follow-up question, is there a size that you know for adults versus kids?
Yeah, so the number in general is about the same. So sometimes it's increased to maybe 10 millimeters, but in adults, oftentimes we'll see that the right side of the heart is enlarged. Or you may see something called pulmonary hypertension, which is high blood pressures in the lungs because of the extra flow. Those would be other reasons to close it. If the hole is relatively small and the size of the heart is not enlarged, oftentimes we would not necessarily close all of those in adults. Again, many of these are done in the cath lab with a device. It's essentially an outpatient / one-night procedure. So the level for actually getting it done is starting to come down more and more as it's a much simpler procedure that doesn't need surgery. Okay. So now that we've decided that your child or you may need surgery, obviously there are new concerns. And I'm going to turn this over to Noelle, but start by simply saying Alagille kids often bring with them a lot of questions. It's not just about the heart. There's many other systems that are often involved. And so the concerns that I have as a cardiologist and our cardiac surgeons have is, what else do we need to worry about? What else is going to complicate the surgery? What else is going to complicate the recovery? And what else do we need to be thinking about as we prepare to do open heart surgery in these very complicated kids? Noelle?
Great. So my name again is Noelle. I'm one of the liver doctors here at Stanford. And so my small section was to talk about, I guess, from the patient, the family's perspective, what it would look like for a patient that was coming here for cardiac surgery. But in the process of that, just talking in general, because I think it's been such a learning process for our group as we built this program and are learning, like Jeff said, about all the different parts or different systems that are involved. So hopefully it's applicable outside of our program as well. I wanted to show, we built this website, but I wanted to show our cover models. They're lovely. It's Roberta and her daughters. Next slide, please. So before, and this is a constant evolution, which has been really nice. So like as we learn more, we change our workflow, and that's changing constantly. I would say like we've changed it this week, we changed it last week, and it's always adapting for the better. So what we do now is that often patients are coming from very, very often they're coming from outside of the local area. And so we start with doing a video visit. So it's one of the nice things to have telemedicine as a tool. We've done it outside the country. We've done it outside of the state. We've done it at all hours, many, many early hours in the morning. But it's just the ability to meet a patient, because you probably had the experience where you go and someone's like looking at your records in the moment that they're meeting you, and it still ends up working out, but it's just nice to give us an opportunity to do all of that ahead of time. to be able to really understand the patient, the child, and their family and their history. So we do a video visit as far advanced as we can, as soon as we know that surgery is scheduled. We built out an Alagille syndrome clinic, and that's myself and Jeff. And then when we formally have it for the in-person visits, and even when we have the virtual visits, we have an Alagille syndrome dietitian who's on the cardiology side that joins us. And then we do labs locally if we're able. And the reason is some of them are ones that we could get the day before a surgery or a couple days before the surgery, but as part of the process that I'll talk about a little bit more shortly, is that we are the whole intention is to think about all parts of that child related to all their organ systems and doing everything we can to make their cardiac surgery as safe as possible. And part of that is thinking about their bleeding risk. And so we've partnered with a hematologist here who has a special interest in children with Alagille syndrome. And so we have started sending some special studies to think about how a child clots their blood far in advance, and some of those take a couple of weeks. And that's been really impactful and a really important part of our program as we've developed it, learning more about that. She just came to our Alagille syndrome program meeting yesterday to do, we called it sort of a boot camp, but just so that we're all speaking the same language when we're talking about these studies and thinking about a child with Alagille syndrome. And we've also partnered with a kidney specialist who helps us think. I think what's been so great about this program is the learning, at least from our personal perspective, on I'm functioning as a liver doctor, Jeff's functioning as a heart doctor, but together we're thinking about all the systems. And that's been a really great learning experience. So it's really asking our kidney partners, knowing about certain kidney complications that a child with Alagille syndrome can have, what should be the screening that we're just starting to do for every patient. So regardless of their known kidney history, because what's been really, again, just an immensely wonderful part of this program is meeting families in more remote areas where I think we had a family that said, we don't have a gastroenterologist in our state. And this is the first time I've talked to somebody who knows something about Alagille syndrome. And we think that's just such an amazing experience to have. And we want to know everything that we should be thinking to do to screen that patient. Next slide, please. So we sort of template this into our notes, but it's just a reminder to ourselves that not only are we thinking about the heart, liver, we're thinking about do they have a higher risk of bleeding and how are we testing for that? Do they have known kidney involvement and we're screening for that involvement? We think about abnormalities of the blood vessels and how to screen for that, which I'll talk about more shortly. And then we also have partners in rheumatology and joints, and partners in endocrinology, or thinking about hormones, or more specifically bones for a child here that we also partner with. Do they have itching? How are they growing? We template all that because we want to know all of those things before they arrive for their surgery. Next slide. And then we have a weekly meeting, and that's probably not important for families to know, but I think I only mention it because it's like an hour that we dedicate every week to thinking about the individual patient. So I have a whiteboard you guys can't see here that has all the patients I'm thinking about, all the things that are in process, and all the things we're doing to make sure that their passage here and then through their surgery is as safe as possible. And then we use that opportunity to invite other subspecialists to come, or invited speakers, or just to really think holistically about a child. And it's Jeff and myself, Michelle Ogawa, who's a nurse practitioner in cardiology, Jennifer Scheck, who's part of the pulmonary artery reconstruction group, also within cardiology, and Danielle Leckie and Ashley Ward, who are our program coordinators, who interface most often with families. Next slide. And then I mentioned Dr. Lowe. So she is a pediatric hematologist, and her role is helping us create a very tailored plan for a patient. So we have the screening labs that she wants. We are starting to get those now as many weeks in advance as possible. And then she reviews those, meets the patient either by a virtual visit or when they come here, and then has a very, again, tailored plan related to that patient and related to what some of their blood tests show. And it's been really instrumental and identifying where maybe it wasn't being identified before, a patient's intrinsic or internal bleeding risk and how to prevent that. So giving a medication right before the surgery to prevent bleeding. Or we had a patient that was going to get a dental surgery, and it was thinking about, okay, because that has to do with the teeth, the risk of bleeding, we think about it in a different way. They need this medication when they're in the operating room this medication after, it becomes very tailored to that patient. Next slide. I mentioned our kidney partner, Dr. Cynthia Wong, is one of our pediatric kidney doctors, again, with a special interest in Alagille syndrome. So she helps us think about children that, again, they have a single kidney, or they have renal tubular acidosis, or they have renal cyst, or another part of their kidneys that's known to be involved. So meeting those patients as well by video or when they come here in person. And then also she helped us with this screening process that we're starting to do for any child. So it's things like getting urine studies while they're here to look for protein that's in their urine that maybe wasn't identified before, and thinking about their kidney function, not only related to some typical blood tests like BUN creatinine and cystatin C. So just helping us think about really to surveil and then potentially detect a child that has kidney involvement that maybe wasn't known before. Next slide. And then when they come here, so we met them virtually. When they come here, Jeff and I both get to go meet them in our heart center, which is always a pleasure because you've been thinking, you've had that child's name in your head for so long. You met them virtually, which isn't the same sometimes, often, as meeting someone in person. We go over all the blood work. We think about additional studies that we needed to get here maybe that we couldn't get locally before they came. And that visit's always so fun. Next slide. And then we have it on our website, but we're just so proud of all these partners in different subspecialties that most children don't need, but if they happen to, we have it available. So we have 3 neurologists or brain doctors, because they each have a different specialty that they're interested in related to Alagille syndrome, a partner in neurosurgery, rheumatology, genetics, endocrinology, or thinking specifically about bones, 2 partners in endocrinology, and an eye doctor as well. Next slide. And then should a child ever need it? So as part of screening before major surgery, and sometimes it's complicated before a cardiac surgery because it's having a child under anesthesia with a cardiac condition, but we've developed an MRI protocol to think about how do you look at the blood vessels from the brain all the way down fully through the belly to identify some of those abnormal blood vessels in advance. And if we do need it, we have a neurosurgery partner, Dr. Steinberg, who is also part or developed the Moya Center here. Next slide. And then lastly, we're really privileged not only to have great cardiac surgeons, but to also have great liver transplant surgeons should a child need it. So sometimes a child's coming for cardiac surgery, often to return back home, to become a candidate to return back home for a liver transplant. It always is a value that to have a liver transplant surgeon. Dr. Gallo has again a special interest in children with Alagille syndrome, to be able to meet that child, help to think about them, and should they end up getting their liver transplant here at Stanford, meets them very, very early, all the way before their cardiac surgery, all the way through when they're actually eligible and listed for liver transplant. Next slide. And then there's a weekly cardiac surgery conference with all the cardiac surgeons, Drs. Hanley, Dr. Ma, and some of the other cardiology or pulmonary artery reconstruction partners. And it's been, again, a real pleasure from my perspective, at least a liver person, to be invited every time there's a child with Alagille syndrome, to be able to talk not only on behalf of the liver, but sort of more holistically, to mention the things that we know about the kidneys or their bleeding, their risk of bleeding, and to really our goal is to bring that whole package so that by the time they're presented at that surgical conference, which they've already been presented earlier, but as the surgery nears, to say these are the things we've done to fully understand this child, to decrease their risk leading up to cardiac surgery, and make sure that information is cross-shared. So that's every week. Next slide. Oh boy, that was the end of my part. Thank you.
Thanks, Noel. So the question becomes, how can we treat some of these problems with the pulmonary arteries? Because these are, again, the most common things that we see. So one way that I think some centers approach this is using cardiac catheterization and balloons and stents. And I will simply say that if the teams are going to be using balloons and stents, everyone should be aware. It often requires multiple procedures. Unfortunately, the procedures are not always successful. And that, in fact, requires the multiple procedures. Now, We obviously have a very strong bias that all kids with pulmonary artery stenosis should have surgery to treat this problem. But to be perfectly candid, surgery may not be an option in some cases. It could be because there are other morbidities that make surgery not possible. It could be, quite frankly, that the surgeons in a particular area are not comfortable being able to do this highly complex surgery. It could be that insurance will not allow a family to travel to get this done. And it could simply be that the providers at the local institution feel that surgery is not going to be beneficial. So sometimes cardiac catheterization with balloons and stents is the only option. In patients that are sent to us, it's exceedingly rare that the catheterization is the option that's chosen rather than surgical treatment. But again, we have a lot of experience with these types of patients, and the comfort level in other places may not be the same. As Noel was talking about, and as I mentioned, complications in the cath lab, we published this a few years ago, talking about bleeding in patients with Alagille syndrome after their catheterization. And the reason I bring this up is that it doesn't have to be an interventional or a treatment catheterization. Simply going to the cath lab and having somebody moving catheters and wires in and around the pulmonary arteries can sometimes lead to bleeding. So we see this, and we began to study this, and we think we may be on to something, but we haven't got enough information to confirm that. But as I mentioned, beware of balloons and stents, not just because they don't always work, because there are definitely complications that can happen. Now, originally, Dr. Hanley was supposed to be in person, but sadly, or fortunately, depending on how you look at it, he's actually in the OR as we speak, working on a patient with tetralogy and MAPCAs. This is actually a still frame from a video that he did as part of an interactive surgical teaching video that actually allows you, if you're interested, to go perform a unifocalization surgery. So the website's there. And if you have a few minutes, it's actually kind of fun to go do surgery virtually. The way that Dr. Hanley and Dr. Ma and Dr. Martin approach these is that they basically open each of the narrowed areas. So they would open this one, they would open this one, they would open this one, as shown here. And then once it's open, they would put a patch on it, right, to enlarge that area. And as I mentioned, some of the kids with Alagille syndrome have many, many areas of stenosis and narrowing, and may require multiple areas of surgery and multiple patches in order to fix that. When it comes to MAPCAs, what Dr. Hanley and his team do is they take all of the pieces of the puzzle and bring them together to form a full tree. Now you'll notice here, the process of going from here to here often takes anywhere between 10 and 14 hours. So these are highly complex, highly technical, highly difficult procedures that Dr. Hanley and his team perform. So the take-home message from this approach, quite honestly, is that surgery in these patients is quite hard. And this, I think, is why it's often not offered in very many places. This is a paper that one of our colleagues just published. Happily, Noel's on that paper, along with Dr. Hanley and others, looking at 50 of our Alagille patients. And you can see they have the three sort of characteristic or classic diseases I talked about. Here's the pulmonary artery stenosis, right? So that's stenosis by itself. Here's tetralogy with stenosis, but without the MAPCAs. And here's tetralogy with the MAPCAs. So here's the 50 patients. About 3/4 of them end up not only with a full repair, but with a full repair and essentially normal pressures inside their heart. So the key take-home message from this is twofold. Number one, it's a hard thing to do, and it is not risk-free. There are certainly kids that unfortunately die when they go through this process. About 3/4 of them, however, can undergo a complete repair with very low pressures. And once you have very low pressures, that makes the concept of liver transplantation much more palatable. So the two messages are that most patients can undergo repair very successfully, and that this kind of disease, whether it's the pulmonary artery stenosis with or without tetralogy and with or without MAPGAs, this is not in fact a contraindication to liver transplant if the surgery can be done successfully. So from a long-term perspective, kids with congenital heart disease need lifetime follow-up. Once they get to adulthood, it may be only every 3, 4, 5 years, but in general, kids with congenital heart disease get a lifetime of follow-up. For those with tetralogy of Fallot or the pulmonary artery stenosis, what we do is we tend to follow the size and the function of the right ventricle. As I often say, as the right ventricle goes, so goes the symptoms. So if the right ventricle is happy, generally there's no symptoms. If the right ventricle becomes enlarged and the function isn't very good, the heart doesn't pump very efficiently, that's when you tend to see symptoms. So here's a picture on the left of a normal 4-chamber view: left atrium, left ventricle, right atrium, right ventricle. Look at the size comparison of the right ventricle compared to the left ventricle. The right ventricle is much smaller than the left. Here's a patient with tetralogy and MAPGAs, who has been repaired, but their vessels were very small and abnormal. Over time, the right ventricle enlarges from doing so much work and also from having the blood leak backwards from the pulmonary arteries down into the ventricle because the valve doesn't work effectively. And now you can compare the size of this right ventricle, to the left ventricle. So smaller than the LV, much, much larger than the LV. Now, I don't have a slide on it, but I should mention that in some cases, when kids have high blood pressure in their lungs, the cardiologist will sometimes think about using medications to help relax those blood vessels. And those medications may be something called sildenafil or tadalafil or bosentan. Those are medications that in general, their job is to relax pulmonary arteries. If the vessels still have those narrowings in them, then the medications may or may not be particularly helpful. If all of the narrowings are gone and the pressure is still high, then in some instances, those medications actually have been quite helpful. So using those medications in the setting of continuing narrowings or stenoses is likely to be much less effective than actually fixing those narrowings and stenoses. So we always opt to try to get rid of the stenosis before adding medication. But again, sometimes that's not always possible. So a couple take-home messages from the cardiologist. Congenital heart disease is common in patients with Alagille syndrome. If you have not seen a cardiologist, please do so. If you hear pulmonary artery stenosis and an echocardiogram is the only test performed, politely ask if more testing might be helpful. And we are here to help, partner, confirm, nudge, treat, optimize, whatever you and your treating team at home find helpful. We are incredibly fortunate to have our Alagille family travel to see us from all over the US, and as Noel mentioned, all over the world. And I will say that we continue to do this quite humbly. In my world, the understanding of pulmonary vascular abnormalities is still very, very new. It was only a few years ago that we actually even described the common pattern of narrowings or stenosis in these kinds of patients. So we have a lot of work to do in the heart and lung world to catch up to what's already been done in the liver arena, but we are working hard and we hope that we will get there soon. That was Dr. Ebel and I. That's Dr. Gifford, one of our basic scientists. Dr. Gallo, as Noel mentioned, our liver transplant surgeon. And Dr. Hanley live in the OR, working on one of his MAPGA patients. So as we started, we finished by saying thank you to the Alliance. Thank you for making Alagille syndrome important. Thank you for bringing attention to it. And we all are Alagille aware.
Love it. We have a couple of fantastic questions in the chat. Please feel free to put in more. A couple of, well, they're all for you, Jeff. So one of the first questions, maybe they're tied, but for two questions are related to sort of being an adult and how do you advocate for someone to think a little bit differently about Alagille syndrome. So some of the examples are, I'm an adult patient with a heart murmur, but my primary doctor hasn't yet referred me to a cardiologist. So we'll sort of start with that first question, is how does someone self-advocate or sort of help teach their local providers more about Alagille syndrome related to the heart?
Yeah, I think one of the easiest ways to do that, and it is not easy, it's easier, you can start by saying, I was just at this conference. We learned all about the cardiac problems in patients with Alagille syndrome. And the doctors in that program told us specifically that we should have our lung vessels evaluated because the risks of any surgery, whether kidney transplant or lung surgery, or even, quite frankly, a hernia operation, are much greater if the problems in the pulmonary arteries are not understood. Doesn't mean they necessarily need to be treated, but they definitely need to be taken into account. We often find that after a different surgery is done, something comes up and we say, well, of course, because of X, Y, or Z. Rather than find that out after the fact, it's much easier to know it before. So invoking the fact that you were at a conference and that all of this was presented and that the risks are higher, you can also bring up, as Noelle mentioned, the risks of bleeding. Right? So if hypothetically you had narrowings in your pulmonary arteries, and that led to what Noelle described, the acquired von Willebrand system, it may mean, in fact, that there is a much higher bleeding risk that the standard tests that everybody runs before any kind of surgery may not pick up on the abnormality. In fact, we have seen this multiple times, that the entire blood screening testing routine was normal, but they had bleeding issues, and only after we did the advanced testing did we find the actual issues. This is why, as Noelle mentioned, we do this type of screening in all of our patients now. We have learned, we have been burned. And to tell physicians that you have an increased bleeding risk tends to get their attention.
Sort of a follow-up question to that was thinking about some of our families have heard that maybe the vessels, and maybe specifically the pulmonary arteries, but any vessel for a patient feel more delicate from the surgeon's perspective, or may be more likely to have a risk of bleeding. Do we know what causes that? Has been the experience of surgeons or for patients with Alagille syndrome?
So there's two answers. That's a great question. So there's two answers to that question. One is that there are intrinsic issues with the clotting system and the vessels themselves that predispose these patients to bleeding. So as we mentioned, we're now starting to find more and more of these patients have the acquired von Willebrand. And one way to treat, there's a number of different ways to treat that, but before we knew what we were doing, quite candidly, we were often using platelets, a platelet transfusion in the cath lab, to try to stave off bleeding complications in patients in whom we had been in the cath lab multiple times for other reasons and had still, even if they were not being intervened on, had bleeding. So they had gotten platelet transfusions to help with this. But again, that's kind of using a shotgun rather than using a targeted therapy. So because they're at risk for it, because their bleeding is abnormal, there's the risk. The other risk is that the vessels themselves are quite abnormal. So they don't respond very nicely to balloons and stents because they are much thicker and much stiffer than normal pulmonary arteries. So it often requires much, much higher pressure to try to get the lesions to go away. And when you use the higher pressure, you tend to do more damage than if you're able to successfully use lower pressure. Now, that being said, excuse me, the way that balloons work, the way that success happens using a balloon is that you must tear the blood vessel. You must. The way that coronary balloons work is they push the plaque out of the way. The way that balloons in stenosis in a pulmonary artery works is that you must tear that vessel, and then the vessel heals and is larger when it heals. So for patients with abnormal tissue and patients with a higher bleeding risk, knowing that you are going to be tearing these vessels, again, the risk is a bit higher, and the same is true for stents. I see that it asks, is there ever a time when ballooning is appropriate? So in a controlled fashion, when surgery is not an option, for example, we had a patient whose liver disease was bad enough that we did not think it was safe or survivable to undergo open heart surgery. In that patient, we gently used balloons and stents to try to bring the pressure down enough to enable that patient to undergo liver transplantation. The other time that ballooning is appropriate and safe is actually after surgery. So some of the patients, despite having good or perfect or excellent surgery, some of these vessels will narrow again over time. Those vessels oftentimes will respond quite nicely to balloons. In general, we tend to do sort of smaller areas, smaller vessels with balloons, but if there are big areas that still have significant narrowings, we oftentimes will readdress those in the OR as well.
What about, to ask some of the other questions? So I guess thinking about an adult patient, is there a routine checkup? So that had some heart involvement. So the example was maybe they've had some caths in the past, stents, echoes when they were younger. Is there sort of a routine follow-up they should have when they're older?
Yeah, that's a fantastic question. So those are two different questions. So if somebody said that there was a minor heart involvement, but they had stents placed, those are probably not the same thing. I would say a minor heart involvement is something where people just stare at it and nothing needs to be done, or they could be treated and there's no residual disease. So for example, an atrial septal defect that gets a device and the hole is closed and there's no more flow. Even for somebody with something as simple as an atrial septal defect, we tend to recommend that they get followed up, for example, every 5 years, right? We're constantly learning new things about the devices. We're constantly learning new things about the surgeries. Even if you had open heart surgery for an atrial septal defect, which is a very simple lesion, there are long-term risks. And that could be something as simple as an arrhythmia. And you may be feeling palpitations, not really chalking it up to your heart. And obviously seeing a cardiologist may help with that. For people who have had stents or ballooning done, certainly following up at a minimum every few years as an adult would be quite reasonable.
All right, and we see folks that are raising your hands. Thank you so much. I promise we'll get to you. Going in order, so I don't forget, so sort of going back to bleeding risk, a question is that only cardiopulmonary or general post-op bleeding, such as a cath insertion site?
Yeah, the bleeding risk exists regardless of what you're doing. Obviously, the risk of something more significant happening depends on how significant the actual procedure is. So for example, simply putting a catheter in an artery is more risky than putting a catheter in a vein because the artery is under much higher pressure, right? Pushing a catheter through the heart and into the lungs is a higher risk than, for example, just having an IV placed. So the risk is all relative, but just because you're not having open heart surgery doesn't mean the risk doesn't exist. As I showed in the paper that I just put the little headline up there, those bleeding complications happen even in patients who did not have any interventions done. So simply having the catheterization and moving the catheters around the vessels led to bleeding.
All right, our next question, do we have any documents that patient, going back to like the patient as an advocate, but also how we can help that patient advocate on their own behalf, are there any documents that we have or others have that patients can take to their doctors to help them understand the seriousness of Alagille syndrome as it relates to their surgical risk?
Yeah, another terrific question. So there is information on the Alagille Alliance website that talks about all of the different issues that patients with Alagille syndrome have. And being able to show this to your primary doctors will hopefully educate them, or if not educate them, at least worry them enough to enlist the help of some of the other providers.
Okay, another question for patient that had an MRI. They said a specific question, but helps for like adult follow-up. If the last one was in 2016, how often this patient had, says peripheral and intrapulmonary stenoses, how often should they be getting, I presume, a cardiac MRI?
Yeah, so the big question is what needs to be done after the MRI. So if the MRI finds a lot of areas of narrowing that need attention, then they need attention. If the MRI is to simply make sure that they haven't gotten worse, then a lung perfusion scan is much simpler and much easier and much cheaper than an MRI. The other thing to remember is that the overwhelming majority of stenoses in the pulmonary arteries don't tend to progress. So if they're mild to begin with, if they're very mild and there's only a few of them, and the pressure inside the right ventricle is low, we will often just follow those patients to mostly make sure that the right ventricle remains happy. If there's a bunch of narrowings in the pulmonary arteries that haven't been taken care of, then simply following them by MRI doesn't provide a lot of benefit. Now, that being said, the other reason that we tend to get MRIs is to look at the function and the size of the right ventricle. So if the MRI in your case is specifically to look at the pulmonary arteries, probably not as helpful as a lung scan, assuming that things are stable. And even if the lung scan is stable a few times, we tend not to repeat those very often. Again, it depends on the degree of the disease. If your MRI, however, was for the size and function of the right heart, those we tend to do every 5 years or so, if not sooner, depending on what we see by echo.
Thank you to Cher, who posted a link in the chat for some of the documents related to Alagille syndrome that Jeff was also referencing. And then Jeff, there's a longer question. I'll try to summarize it, maybe 4 up. So it's about a patient that is now an adult, 18 years old, but he has tetralogy of Fallot, pulmonary atresia, and when he was 2 years old, he had a unifocalization surgery and has had a number of the 14 cardiac catheterizations since then, 2 conduit replacements, and we'll have a number of cardiac catheterizations in the future. So the question is thinking about, is unifocalization again an option? I know this is very specific to a patient, but in general, is unifocalization a future option for a patient that's already had a number of open cardiac surgeries, stents placed, et cetera?
The short answer is yes. So we actually see a lot of patients who have had procedures and surgeries and stents done elsewhere that come to us for second opinions. I will tell you that we have a very good relationship with the CHOP team. They do send their patients to us. So if you said to them that you'd like him or her to come out for a second opinion, I would be stunned if they didn't say that they would be fine with that. From the perspective of the conduit, conduits are often replaced multiple times. In the current era, once a conduit is large enough to be what we would consider to be adult sized, if the issue is, for example, regurgitation or leakage of blood from the pulmonary arteries back down into the ventricle, nowadays those can actually be performed in the catheterization lab. So you can have new valves placed inside those conduits in the cath lab. And I'm pretty sure that the CHOP team knows that and knows how to do that. They have a spectacular cath lab team there. From the perspective of the stents and the balloons, it depends on whether the team there and or the team here believes that there's actually anything else that can be accomplished. If the images were reviewed by Dr. Hanley or Dr. Ma, Dr. Martin, and they believe that there was nothing to offer, then the answer to your question is yes, caths with balloons and stents are the only option. If, however, the belief is that the surgeons can get in there and open those areas up, then obviously that would be something worth considering.
Great. Nathan, thank you. You've had your hand up for so long. I see your question in the chat, but if you wanted to unmute, you're welcome to ask it as well, or else I can also read it.
Oh, hi.
Again.
So my daughter's cardiologist explained that ALGS patients tend to have thinner aortic walls. And so she said that stents would potentially be like run the risk of tearing. But then I thought that I heard you explain that they tend to have thicker aortic walls, and so the ballooning would be less effective. I just want to make sure I understood what you're explaining and what you tend to see in terms of like if it tends to be thicker walls or thinner walls. Thank you very much.
Yeah, terrific question. And the short answer is both. It just depends on how you put the picture together. So the pulmonary artery, the main pulmonary artery especially, lies right next to the aorta. And so in patients with Alagille syndrome, as I mentioned, most of the disease is actually in the pulmonary arteries. And so the balloons and stents that I'm talking about are in the pulmonary arteries. I believe what your cardiologist is mentioning is that if we are ballooning and stenting the pulmonary arteries, it may actually affect the aorta, right? So the aorta is not necessarily thinner per se in Alagille patients, but the aorta is thinner than the pulmonary arteries. So the pulmonary arteries are affected, and those are very, very thick, whereas the aorta is quote unquote normal and very thin in comparison. So I think your cardiologist is worried about potentially damaging the aorta by using balloons and stents in the pulmonary arteries. Does that make sense?
Yes, thank you.
And this doesn't have to be the last question of the session, but the last question that I at least see in the chat was asking about if we offer a second opinion option, not only related to sort of cardiac conditions related to Alagille syndrome, but for even patients with non-cardiac conditions.
The short answer is yes. So obviously the two biggest issues that kids with Alagille tend to have are with their liver or with their heart, and that's why Noelle and I are sitting here. But if there are other pieces of the disease, and fortunately not heart or liver related, we would be happy to get you guys plugged in with neurosurgeon for Moya Moya, or our kidney doctors, or our blood doctors, whoever would be helpful to you. We are very fortunate to have a lot of people with a lot of interest in Alagille. It makes our jobs a lot easier.
And I put our website in the chat and also our email address and some of our contact information that goes directly to a coordinator, but then she shares with the rest of us. A question, do we give second opinions to adults too?
Yes, as they say, adults are people too.
I saw that, I think Karen had her hand up, if I saw correctly, if you wanted to unmute.
So while we're waiting for you to unmute, it turns out that, for example, the cardiac surgeons who do adults are the same cardiac surgeons who do the kids. And the liver transplant doctors who do adults are the same liver transplant doctors who do kids, which is particularly convenient for patients with Alagille syndrome. Okay, any other questions? Any other ways that Noelle and I can be helpful?
A question about, oh man, you're straining the cardiologist and the hepatologist. A question, can we touch on Moya Moya briefly, what it is and what to be aware of?
Go ahead, Noelle, you're the Moya Moya.
So I think, at least from our perspective, so the way we think, we have been thinking about it, and we're still, so we've developed a protocol, which is not unique. It can be a protocol done everywhere, but we developed it with our radiologist to think about how do you do an MRI fairly quickly. So I guess when I say developed, it's like protocoled on the radiology side, because you're saying we're putting this, if it's a young child, it's under anesthesia. What are the things we want to look at, and how sort of fast can you get it done so that anesthesia is compressed, but you're looking at all the things you need to. And then the separate question is when to do screening. So when we've talked to other experts, Dr. Piccoli, Dr. Kamath, and others, and then also to our neurosurgery partner, Dr. Gary Steinberg, it's when do you think about screening a patient, specifically for something like Moya Moya or a vascular anomaly, not only for Moya Moya for the brain, but a blood vessel that is abnormal in a sense that it could cause either bleeding complications that we would certainly want to know about before a surgery, or before it really like came to a head and that patient had a complication from it. So our practice has been to screen patients before they get a major surgery if we're able to. So again, for a patient with a cardiac condition, sometimes that may not be possible under anesthesia before their cardiac surgery, but that's always our aim. Certainly for a patient before liver transplant surgery, and sort of our general view has been before any major surgery, we would want to know about any vascular anomalies or things that could be repaired so that it doesn't become an issue after the surgery. So you take care of you identify it and you take care of it so it's not causing risk to that patient around the time of surgery or after the surgery. Other than that, so either like at any age before major surgery, for any patient that's having sort of any neurologic type symptoms that make you worry that there's something going on with the blood vessels. And by that, I mean like things that you would think about, like, oh, if someone was having a stroke or there's changes with vision, any neurologic brain symptoms would be a reason to have a patient do that, even if they needed anesthesia, even if it was a young child. And then separate from that, for the like patient that doesn't need a surgery, has no symptoms, when they make, by the time they make it to an age where they're able to do an MRI, which is like a long time in a, you know, big noisy tube without anesthesia, is sort of has been our practice. At least that's the time to do an MRI for them. And then in talking with at least our neurosurgeon, thinking about doing surveillance from whatever point it starts to sort of every 5 years is a thought. And I think folks vary, and we're still learning as we're doing more MRIs for children, as we're identifying things. Some of those guidelines, at least within our institution or more globally, might change, but that's sort of been our practice to say. And the reason for the every 5 years is that it can develop over time. And so even if it was 5 years ago, it wasn't present, that should still sort of be a part of screening. So that's been our philosophy about how we think about it in general.
And just to tack on to that, two things. So just in broad sweeping terms, so moya are abnormalities in the blood vessels in the brain, right? So the vessels are abnormally small. And so in severe cases, you know, neurosurgeries need to take care of those. But again, as Noelle indicated, whether it's, you know, aneurysms that form or risks for bleeding that form, it's obviously something that screening for should be done. The second thing is, I will give a plug because I think Dr. Anderson is talking about vascular stuff tomorrow morning at 9:15. So I wouldn't be surprised if this gets brought up there as well.
Noelle, I think someone has their hand up also.
Ooh, thank you. I just saw it and I lost it. Elizabeth? Anybody's welcome to unmute and ask the question this time, of course.
For more and for more information about the cardiac in children, is it on the Alagille Alliance website, or I just have more questions because I feel like we're falling through the cracks. So the more information I can bring to our local doctor, I think might help us get the scans and everything that we need.
But I think her mom's right. She probably is a little tired.
Yeah, so Dr. Anderson sent something to the chat that said she will be talking about that tomorrow. So hopefully you will have some beautiful information to share with your local doctors. There's also information, I know there's information on the Stanford website in the Moya Center. So you can certainly look there. And if you don't find what you're looking for, please reach out to either Noelle or myself, and we'll put together some information for you. I think he's on, Dr. Piccoli also has a great deal of experience with patients with Moya, so I suspect he has some resources for you as well.
Okay, so it's almost 2:15. The next session is Dr. Piccoli of ALGS and liver. This was amazing, you guys. Just thank you so much. It was wonderful. I don't know if anybody wants to take a quick break and hop back in at 2:30. Does that sound okay? And any other questions, please feel free to send them to us. and we will shoot them off to Dr. Evil and Dr. Feinstein as we keep going.
Our thanks again to everybody here and for you guys for putting on this amazing conference. We really appreciate you.
Thank you so much for coming.
As a reminder, you'll X out of this and go back into the lobby and navigate to the auditorium to launch the next session, which begins in about 15 minutes.
See you there. Bye.
Thank you. Bye.